This is part 2 of GI disorders, and it's going to address vomiting and diarrhea. Make sure that you watch the con videos that are about gastroenteritis and viral gastroenteritis. So what are the risk factors? When you look at that little one sitting on the floor, that's the risk factor. They're small and they put everything in their mouth. Premature babies and young infants are at risk because they rely on others to care for them and they don't wash their hands. They have altered immune systems. Of course, our children who have chronic conditions also are going to be at risk for the same reason. And then we put all these children together in crowded conditions. School, daycare, church school, you name it, cluster a bunch of kids together and they're going to spread germs like wildfire. They also eat meals outside of the home, and so that increases the risk of a pathogenic foodborne bacteria. By far the most common causes of diarrhea are a virus. It goes around, everybody gets it, everybody gets better. But we can also acquire bacterial, and sometimes that bacterial is because we've given the child antibiotics and we've caused C. diff. Can be parasitic, it can be fungal, and these are usually the outliers. Some children will have a food intolerance that causes them to have an osmotic type diarrhea. Malabsorption from short gut will cause diarrhea stools, medications, and the most common being antibiotics, but of course there are others. When we look at diseases that cause diarrhea, your inflammatory bowel disease and your ulcerative colitis will cause diarrhea, and these are going to be bloody diarrheas. Irritable bowel syndrome can either be diarrhea or constipation, and it can be a combination. Now, the interesting thing about the inflammatory bowel diseases, which would be Crohn's and UC, the diarrhea these kids get, it doesn't matter what time of the day or night. When they have to go, they have to go. Versus irritable bowel syndrome, it doesn't wake them at night. And intestinal obstruction can cause diarrhea as the liquid stool is trying to go around the obstruction. And of course, emotional stress can give you diarrhea. So it can be acute, sudden onset, and self-limiting. Food poisoning. You eat, several hours later, you have your symptoms. Infections. Now, these viruses, the rotavirus is the worst for the children because it causes such profound diarrhea. We're still in the rotavirus season between November and May, and this can last from 3 to 9 days. In addition to C. diff, other common bacterial type of diarrheas are Salmonella and Shigella, and you have to get that from somebody else, like a food or somebody who didn't wash their hands. Parasites common because we go out, we go camping, we drink the water, and next thing you know, you have Giardia. Systemic diseases in kids, who would think diarrhea would accompany a UTI or otitis media? But we're talking kids. They forgot to read the book. Toxins can also lead to diarrhea, and then overfeeding new foods that the child isn't ready for, and large quantities of fruit and juice can also increase vomiting and or diarrhea. So this slide basically just reiterates what I just said, but it's clumped nicely about when you would expect rota, what the symptoms are. The parasites, they can have a lot of gas and cramping. So chronic diarrhea, we define that as diarrhea that occurs and lasts actually longer than 2 to 4 weeks. We can have a mechanical, as in an ileus. Now that doesn't last longer than 2 to 4 weeks, but we can have an ileus and then we can have other obstructions, but typically this is much shorter time frame. Food allergies and sensitivities, because it's recurring, will last longer than 2 to 4 weeks. Inflammatory bowel disease, definitely more than 2 to 4 weeks. And because of the age group when it occurs, that late school age or early adolescence into the late adolescence, these kids aren't telling their parents that they're having all this problem with their poop. And then we have a variety of the malabsorption conditions. When a child is admitted with vomiting and diarrhea, you need to get the history. When did it start? How often are they vomiting? Do they have diarrhea? how many stools per day, what does it look like, what's the consistency of the stool, what's the color, what's the odor. And then when the child is vomiting, you need to know, are they just vomiting like you and I are used to vomiting, or is it projectile? Because a projectile sends babies down a different pathway, that they're not sick, they actually have a mechanical obstruction. Do they have signs and symptoms of dehydration? And so you've already gone through the fluid and electrolytes module, and so you need to go through that head-to-toe assessment. And an important thing that you need to ask about for any baby who is not toilet trained or can't void independently is how many wet diapers have they had in the past 8 hours and in the past 24 hours, and always make sure that you ask, what is this kid's norm? Remember, people who leave these Pampers on, they might just change them twice a day, but that doesn't mean that the kid hasn't filled it up and it's weighing about 5 pounds. This picture here shows very severe dehydration, and you can see how the skin just remains tented and it's very slow to go back down. Hopefully we're going to get a kid in long before they look like this. So we're going to talk a little bit about rotavirus because it is the most common cause of diarrhea in young children. So 80% of kids less than 1 year of age will have rotavirus. And by the time they're 5, just about everybody's had it. So it's an acute onset of diarrhea, and it causes very rapid dehydration because they're stooling. It is a virus that incubates over 1 to 3 days, and like I said earlier, that the diarrhea can last a little more than a week, and it can be accompanied by vomiting, plus or minus fever, as well as abdominal pain strictly from the cramping. And you can see this little guy in the tub, he has got poop everywhere, because that's how bad it is. Our focus is going to be on hydration. Is this kid interested in drinking? How many stools? And you need to look at the consistency of the stools yourself and the wet diapers, and then look at the vital signs. So review your module on fluid and electrolytes to see how these kids are going to have a higher heart rate before they're going to start going into that dehydration shock where the blood pressure goes down. The diagnostic studies that you will be collecting and sending will be a culture and stool for ovin parasites. We can send off for occult blood, and they're looking for inflammatory conditions when we're looking at the blood. And then there's other things that are really unusual, the reducing substances, sugar, fecal fat, and pH, and that's for the malabsorption type conditions. Sometimes when somebody vomits recurrently or repeatedly, we might send that off for an occult blood and get a pH, but usually not. Now, other labs that we're going to do is going to be a blood count. We're going to look at their hemoglobin and hematocrit, because when you have bloody diarrhea, of course, you're going to drop your H&H. We look at the chemistries, the electrolytes, the CO2, BUN, and creatinine. And then if there's other tests that we're looking for toxins, we'll send those off. So what do you do when you care for a child who's vomiting? Well, you try and find out what's causing them to vomit and take it away. So you need to observe when the kid vomits, how much they vomit, what were they doing beforehand. Assess them for fever. Do they have a rash that's developing? They came in with vomiting, now they're having diarrhea. So the things we do to stop the kid from vomiting is we give them Zofran, which is the ondansetron, and it's 0.15 milligrams per kilo per dose, and we give that to them IV. If they're not NPO, we'll give them sips of liquids. You don't want to give them a big bolus of fluid. It's just going to make them vomit and have diarrhea again, so we just want to give them small sips. And if they're not tolerating it, we'll just make them NPO, and we're going to start an IV. If they have an obstruction, we'll put in an NG tube. It's very important that you do an accurate I&O, because this is what's going to determine whether or not this kid gets to go home. And then always evaluate how effective all of our therapies are. Make sure that when there is a child who is having a lot of vomiting, that you elevate that head of the bed so they don't aspirate. So our goal is to maintain fluid and electrolyte balance, keep their skin intact, especially if they're having diarrhea, and provide nutrition. For mild to moderate diarrhea, we're going to give oral rehydration therapy, and then we give them a bland diet. But for the severe vomiting and diarrhea, and they have ongoing losses, we're going to start them at NPO for 4 to 8 hours, maybe a little bit longer, and then gradually reintroduce oral rehydration. Pedialyte, we have Pedialyte popsicles. Those tend to go down real well. If they're thinking that there's GI pathology, then you'll put down an NG tube and you're going to monitor what the output is out of the NG tube. So when we give IV fluids, you're going to calculate what their maintenance is. And if the physician says that, okay, they're 10% dehydrated, we're going to add that additional 10% and administer those fluids. And be prepared to administer boluses. Remember the 20 mLs per kilo over no longer than a 30-minute window. And then if they have a big output out of the NG tube, then we're going to do ml to ml replacement. So if they have 50 mLs out at the end of the shift or at the end of 4 hours, whenever they tell us to measure it, then we're going to add back the fluids IV as a replacement. You should be very familiar with this. This is what putting an NG tube down is, so that we can empty the stomach. This is the formula that we use for mild dehydration, moderate dehydration, and severe dehydration. And if I were you, I would flip this out of the slides, put it in your peripheral brain, and you should know who gets what in terms of dehydration. So how do we rehydrate? Well, we can give them oral if they're more than 3 months of age, and if they're more than 5 kilos, and as long as they are alert and only mildly dehydrated. But then you're doing that in the emergency room or the clinic. Who gets admitted? Prolonged illness, they're not tolerating POs, they're less than 3 months of age or less than 5 kilos in weight. Or the mom reports that they've already done all of the things we've asked them to do and the kid isn't getting better. Or if the child has no urine output. If they're admitted, always reassess the hydration status, because we have a tendency to forget when we give IV fluids that these kids perk up really quickly, and next thing you know, we've overhydrated them. So we're going to initiate IV hydration, NPO, until we're allowed to advance the diet. We may put the child on contact precautions for diarrhea because right now we don't know what they have and if it's contagious, so we'll put them on contact, and then strict INO. You need to provide good skin care. Check their diapers frequently and cleaned with a mild soap and water. We can use diaper wipes, but we don't want to use perfumes because that'll make that very sore bottom burn. We apply barriers to the diaper area, and you can even do it for an older kid if they already have a rash around their anal sphincter. Then we can use butt paste or Desitin, A&D ointment, anything like that to protect the skin. For the smaller kids that are in diapers, or even some of the bigger kids, we can leave their bottom open to air. And believe it or not, this is really strange when you see this, we just give them blow-by oxygen and it helps that skin heal. If it looks like they have a fungal infection in addition to the dermatitis from the stool, then we can give these other products, the hydrocortisone and the nystatin. Zinc oxide is pretty much like Desitin. And so these are the diaper rashes that I'm talking about. That's pretty nasty, and that's a kid who just sat in stool. This little guy on the left, he sat in stool for way too long. And so you're going to be putting on a very thick layer of cream. It's hard to get it off when they stool again, but clean as best you can and then reapply. So this ends gastroenteritis, vomiting, and diarrhea.